Good morning, everyone. Actually, good afternoon to you over there. It's just about 10 o'clock in Honolulu, and my name is Peter Sai, and today we're going to go through about four different discussions and topics. Namely, the first one is thoracic trauma, followed by aortic valve. I think we're going to have a short break, and then follow it up with coronary arterial disease and cardiac syndrome, and then basically mechanical assist device to top it off, and then the Q&A session to sort of finalize the day. So the first series of talk is basically on thoracic trauma. A little bit of my background: I trained at Baylor and over at Texas Heart, and after I finished, I actually was working as faculty at Ben Taub with Ken Maddox and Joe Caselli. So for 10 years, I was there doing both cardiac and trauma, which is kind of interesting. Wrote a lot of chapters with Ken Maddox, who's also a heart surgeon, and had some really insight, understanding of what trauma is. So hopefully I can bring that to you over here and go from there. All right. So without further ado, the topic on cardiac and thoracic trauma. So in general, what you need to do, the slides I placed together, and you might have them in the previous copies, are pretty much the key things that you would be tested on. And so when people talk about coronary artery injuries, you got to remember that the LAD is the most commonly injured vessel, in blunt and penetrating, both blunt and penetrating. And it's basically because of its location. It's actually anterior, a little bit to the lateral part of the chest wall, but then with all injuries of the coronary, that will be the most prominent vessel to be injured. This is then followed by the RCA, again, no surprise, with its anatomical location, how it exits the aortic root. And then last but not least, the circumflex. And that'll be a very rare vessel to injure because of its location. Now, remember, when you have distal injuries to the distal third of the heart, that can be ligated with a small sort of infarction, and that's acceptable. Now, not all people will tolerate it, but in case of a trauma, and you see that it's actually distal third, instead of trying to repair it, first of all, if you're going to try to repair it, it's almost impossible in a trauma situation. You need to do either all pump at best, and then you have the facility, you get to put the patient on pump, and patients like that usually have multi trauma and organs, and they won't really tolerate that procedure well. So the answer to that would be in the distal third, you can ligate easily. Now, anything that's proximal, unfortunately, then you have to actually bypass it or stent it in this case, because of the following reason: you get a major MI, and that's not a good happy heart if you do that. The specific cardiac injuries would be after you're injured the heart, you nick it, for example, it doesn't blow out. It will basically create a ventricular aneurysm, and it's very rare. Now, if the coronaries are normal, then the injury is in the myocardium, right? So you have a bruised heart, if you will, and the myocardiopcytes die, and it becomes scar and thin out and start to bloom, and it's not secondary to the coronary injury, right? And which in this case, if you have a true injury through and through, and it's a small one, you might develop a pseudoaneurysm, which is very different from a true aneurysm. In terms of traumatic septal defects, this is important to note. It's usually located in the muscular septum near the apex, because anything more proximal would result in significant exsanguination. The patient won't do well to begin with. And the way you see it is that you have a new systolic murmur and an acute heart failure because of the left to right shunt. Diagnosis with either a TTE, but then if you have chest wall trauma with a lot of ecchymosis and edema and swelling, you can't really see it, so you resort to a TEE to evaluate the defect. Again, oxygen saturation step up more than about 20 between the right atrium and right ventricle is diagnostic of left to right shunt, which makes sense because now you have fresh oxygen and blood coming in, and so there's a difference in oxygen saturation between RA and RV. Now, In terms of the defect in the VSD, it's repaired all the time unless the shunt per echo findings and calculation, the QPQS shunt is less than 1.5. And so you can allow that to occur, and hopefully it may close, it may not, but at least it's not physiologically going to be impactful. The use of intra-aortic balloon pump by decreasing the afterload allows the LV to pump selectively, or not selectively, to preferentially pump towards a lower resistance. And so it decreases that shunt, left-right shunt, if you have a VSD in this case. In terms of the valve injury, the aortic valve injury is the most commonly injured valve. And then again, what does that mean? It makes sense because of the location, right? It's right there, dead center. And the mechanism may be from avulsion of commissures, extension of the blunt traumatic aortic rupture at the aortic root when falling from a height. So it's a vertical shearing injury. You can have subsequently AI, aortic regurgitation, and the treatment would be to resuspend the valve in the commissure disruption with pledgeted sutures, much like you would do on an aortic dissection case where you have dissection and basically your commissure is being pulled down. You can actually resuspend it that way. The leaflets injury, if you do see that, usually needs replacement and cannot be repaired. Again, in an acute setting, you don't want to be putzing around where you try to repair, you come up and the repair failed, you still have severe AI. Then you go back and pump, and it's just, prolonged pump run. Replacing it quickly would be the best choice. And then, as we alluded to earlier on, in case of dissection with valve injury, a composite graft may be needed with a coronary implantation like a Bentall. The mitral valve is rarely injured in this case, but more so with chordal or papillary muscle rupture. All right. Again, diagnosis with TEE or TTE, if possible. Again, you can use balloon pump to sort of temper down the severity of the MI or the MR. And replacement is usually the rule. You don't want to just go ahead and try to repair it and put an anaplasty in this. No place to be fancy in this case. You want to go ahead and replace it straightforward. You know that you're going to come off. You're going to have a competent valve in this case. The tricuspid valve, more common